THR and severe Protrusio and Rheumatoid. It's basically a technical discussion how to do a total hip replacement or simple tips, especially for the younger patients. This case is 39 years old male with one side, right side hip involved with severe Protrusio, with marked restriction of the movement, and he's partially the monoarticular rheumatoid mostly. And this is his X-rays pre-op. Now, it's very important to study the X-rays and plan the whole surgery in terms of your technique, in terms of your implant used, and definitely in terms of your reconstruction to build up the acetabulum and also at the same time bring the head or the center of the rotation of the hip out laterally, and of course equalize the limb length. So these are few things which we need to consider. There are some people that recommend as well doing an CT scan, but I personally feel it is not needed in such kind of cases, which I've been showing it here. Now, this is his AP and lateral X-ray, same time seeing a canal. It's always important to look into the canal diameter as well. The complete, sometime we just leave up to here and then don't see the canal down. So you need to see an AP lateral, preferably possibly, and have a good radiological assessment. Now, what are the important points? Very simple points. As I said, the preoperative planning. So you have to template, especially the socket size. Okay, what is the socket is going to use it, and basically, as per the literature, if you go, you need to see that usually nowadays the uncemented socket is more preferable with the bone grafting than the cemented socket with the bone grafting, because the results are much more superior, which I'll talk about it. The component selection, especially on the naturally on the socket side, it has to be a good bone in growing component. Okay, so the porous surface or porous coating or has to be really good, and you need to select a kind of a revision socket which can have a better ingrowth and better fitting as well. Now, in tips of surgical technique, the most important thing is dislocation of the hip. Now, such cases can be definitely even the Krishna was talking, even Anup was talking, and about the basically I do with the posterior approach. Such cases, you need to definitely worry about the sciatic, which is in a close proximity, and naturally identify the neck properly. If you go back to the X-ray, you see it's completely in. So identify the neck properly, and maybe if an in situ osteotomy can be performed, that's the best thing to do it. Sometimes it is recommended, but I have never done it. I have done many cases like this. You may have to do a trochanteric osteotomy as well to visualize and dislocate or cut the neck. Going from an anterior side in such cases where the osteoporosis is huge, completely stiff hips, could lead to a fracture intraoperatively, and which should be avoided. It's also important to have a very good reaming technique, because here what we are going to rely on a rim fit rather than relying onto the bottom fit or socket fit completely. So you have to have a really, really good rim fit socket. So you have to be good at your reaming technique. Of course, when you osteotomize the neck, you can take out the head in a piecemeal, or you can have a very reverse reaming, not to have a powerful reaming to take out the head. So you can have two ways of taking out the head. Naturally, you need to establish a proper offset, and you need to be good at bone grafting technique, and you need to completely fill the socket. So using those principles, this case was performed. If you see that here, the in situ osteotomy was performed. Dislocate is not hip is not dislocated. With the reverse reaming, the whole head was taken out, and whole area is filled with the bone graft. And I've used a completely rim fit socket, used in a screw. Of course, I've kept a little bit horizontal because I don't want to have a stress going on medially on the socket side. So this can be in a situation where you can keep the whole thing to get consolidated in a 6 month to 1 year time, and patient can have a better and better result. And finally, if you see the socket is closely very well. If you see, this is an X-ray which is post-operatively. The stem is not a problem usually, okay, and the limb length is completely equalized. So if you go to even the literature, this technique has been favored by many, and excellent long-term results. Even the 12 years good results have been published in 2018, what the technique, which is very common technique, but it has to be done very carefully. And there are multiple papers which is published. There are paper which is published also saying that in a grade 1 or grade 2 protuso, only doing an unsymmetric socket, not filling the gap with the bone graft, okay, not filling the protuso properly, the losing rate is much higher as compared to the grade 3 or severe protuso, where rim fit solid stable fixation with the bone graft. The revision rate is much higher in a grade 1 and grade 2 when the bone grafting is not done. As compared to the cemented socket with a bone graft, also the revision rate is higher as compared to the uncemented socket, properly used rim fit stable socket with the bone graft. There are many papers which have been published in the literature and which favors this current technique, and you can get an excellent result with such kind of severe protuso case in a rheumatoid or any of the protuso case if you follow the technique correctly. Thank you so much.